Throughout human history, we've died young and quickly. Now, modern medicine gives us wonderfully long lives, but also lingering and expensive deaths. And that's a problem that can haunt our families and could bankrupt our nation's safety net.
This is when she was almost ready to go, because even the first surgery she could talk and she could read. This is probably after her third surgery.
We don't plan for our deaths or talk about what we want. Doctors may not be direct enough. Maybe we pray for a miracle, so we leave our families with complicated and wrenching choices. Ray Brown's experience with his loved ones was emotionally grueling and expensive. It was hard for him to decide when to stop.
We struggled to think what we were going to, and each operation, we knew the doctor said there's a chance that she could die. And we talked, my brother and I talked a long time. And sometimes I'd play devil's advocate with him, but he was always strong. He was a person that felt always positive that my mom's going to make it.
After 3 surgeries over 2 years, which required around-the-clock care, their mother died. Then Ray's brother got sick and had to be hospitalized in intensive care.
This is a birthday party that we had for my brother. And this is my brother right here. And here's his Oakland Raiders. He's all happy. He's getting presents at our house.
A love is so strong, and it's such a strong emotion that it can cloud your thinking. In the case of my mom, she had said, "Ray, I want to pass away right now." And but my brother, it was a different situation, and I did not know what to do with my brother's situation.
Because his brother didn't leave any advance directives, Ray was left to guess what was best for him. And they didn't talk about his future after his release from the hospital. So Ray simply hoped for the best.
My brother, I had this naive manner that my brother was cured, that in Oakland, Pill Hill, they cured him, even though the doctor was very honest and said he could die at any time. And I still felt that my brother would be cured. And he would talk to me, engage me while he stayed at our house. And it just was something I had a nebulous idea that was clouded. That because I knew him in the past, the avid camper and hiker and everything. And I just was clinging to that feeling that he's going to make it. He's going to make it. The doctor said one thing, but he's going to make it. And like he clung to that idea that my mom would make it, and she didn't.
But his brother sickened, leaving Ray with the awful decision as to when to stop treatment.
With the doctor, and I thank God for that doctor, and I thank God for that nurse, I went through it, and a priest came out to give the last rites. And I asked the priest, I said, "Father, am I doing the right thing for my brother? Am I doing the right thing? Because I don't want to kill him." And he I don't remember what he said, but he said, "Everything will be all right. Everything will be all right."
Ray's very grateful for the time it gave him, and he's so appreciative of Medicare's support. But when he looks at the hospital bills, which total almost $300,000, he's shocked by the cost.
I think the ICU offers minute-to-minute monitoring, real-time response to any physiological change. The most rewarding experience that one can have is to take somebody who is on the verge of death and bring them back to health And for a healthy person, that's wonderful, and there are a lot of stories about that. The problem is more often the case as time goes by. The people who come into ICU are increasingly older and sicker with a lot of what we call comorbidities, or lots of diseases, chronic diseases. And it's never really been the case that anybody comes out of an ICU doing better than they did before they came in. And that's important, because some people say ICU, we're going to get, a lot of positive energy and people will be in better shape at that point in time. But they never get better than they were at their baseline, assuming they were stable. Because a lot of things happen in the ICU that are negative. Acquisition of infections, resistant organisms, just the complications of the treatment. There's a lot of things that happen. Tubes go in the throat, lines go in the blood vessels. So there are issues about the treatment that's not completely benign either. So it's a high-tension environment.
When you're very sick, it's easy to end up in ICU, but it's hard to know when to stop.
What I often see is patients wanting to protect the families from their illness, families wanting to protect patients from the patient's illness. And so there's a big gap of communication, where I don't want to tell you how sick I am and I don't want to tell you how sick you are. So we're not going to talk about it. And it's like a big pink elephant in the room. If this chemotherapy is not helping you, and in fact, maybe it's making you sicker. And I use chemotherapy just because it's an easy example. If it's making you sicker, you're not feeling well, you're losing energy, you're losing weight, then maybe we ought to stop the chemotherapy. And that's not giving up, but let's change the focus. The focus is no longer on using a drug to try to control a cancer. The focus is now on let's use medications that are going to help me be free of pain, that are going to help me live my life in a way that gives me quality, that I can be out of the hospital and be at home with my family and help my family take care of me. And if the expectations are that chemotherapy is not going to cure this cancer and is not going to help somebody live better, maybe it helps them live a little longer, but if that person would not want to trade quality life for quantity of life, then we really should take a second look at that treatment plan.
When we did finally get that diagnosis, and it was terminal, and he was so ill at that point as to be critically ill in the intensive care unit at the hospital.
When her husband was released from the hospital, Cheryl cared for him at home throughout the final 4 months of his life. Yet while the expensive care continued, he only got worse.
I honestly felt that his life was ebbing and ending at that point. His pulmonologist strongly lobbied Medicare to cover a new drug, and he was very persuasive, apparently, because Medicare did agree to it.
In addition to caring for a bedridden husband, it was Cheryl's job to obtain and administer the drug every day through a pump.
And his heart just depended on that medication and would have stopped. It did finally, and very easily, very quietly. And I looked and lifted his shirt, t-shirt, and the drug, it was still pumping after his death. I watched and realized that in many aspects this drug prolonged his death and did not really allow him any type of life other than an existence. Gratefully, his mind was clear. He had some appetite. So that part of it was good, but the other part wasn't. And that made me realize absolutely that it would not be a decision that I would make for myself.
So Cheryl has done all the right paperwork and given specific instructions to her children.
I do not want ventilation, that I don't want feeding tube, that I want medication that is, if I'm in pain, that is going to modify that pain, that the best thing they can do for me is to allow my choices to happen, even though I know that it's going to be very hard for them. The medical community, for all the wonderful things that they are able to do and have been so successful with, have lost sight sometimes, particularly towards the end of life as we age, that death is a natural process. No one escapes it.
Even with all the planning in the world, death is still hard. Things happen that you don't expect. Losing someone, it's awful. But Ray, Cheryl, and a growing number of doctors hope that their experiences can move us towards a more humane, dignified, and loving goodbye.
Hey, you're squeezing my hand to the